Welcome to BFR Radio, a podcast dedicated to all things blood flow restriction training. This podcast is proudly sponsored by the BFR.co, where if you want to buy your own BFR cuffs, access online BFR training programs, increase your own BFR knowledge with the accredited BFR.co course, or you want more information about this type of training, this is your one place to go. And I'm your host, Dr. Chris Gavilio. Happy New Year and welcome to BFR Radio. This is our first episode for 2025. It's February already, time has flown. This year also coincides with 15 years of the BFR industry for me. As you may or may not know, the BFR.co is my own BFR product line. It started out as the SRT or Sports Rehab Tourniquet. As it goes with marketing, although the SRT has a nice acronym, it didn't say anything about BFR, hence the change a few years ago to the BFR.co. Before we get into the podcast, quick trip in history for you. The first time I ever saw BFR was around 2008 whilst in the UK working with Bath Rugby Union. A good colleague and friend of mine, Professor Christian Cook, who is a prolific researcher in sports science and elite athletes, handed me this cuff. It was a simple system, an inflatable bladder. No dial to know what the pressure was. So I did a bit of research. Back in 2008, there wasn't as much research as there is today. My first use of BFR was pretty simple. We used an absolute pressure around 140 millimeters of mercury. And we got great results with a few players who had ACL surgery. Then in 2010, it was time to come home back to Australia. A physio who worked back at Bath Rugby contacted me and asked where I got the BFR cuff from. Back then, you couldn't go online and just buy a set of BFR cuffs like you can today. So I thought there was a potential for a product. Long story short, I found a supplier and created a website. Possibly I may have been one of the first online BFR stores, aside from Catsuit, of course. Knowing where BFR has progressed to today and the number of suppliers, perhaps something I should have gone a little harder with. By juggling a full-time job as an S&C coach and a young family, it was something that I am still proud of what I have achieved so far. What's new in 2025? From a product standpoint, I'm happy with the BFR.co system. I receive lots of regular feedback on the quality and fit of product, and even a few customers who have bought more expensive and elaborate systems have stopped using those and bought mine. For the medium lower body cuffs, I currently have a limited edition color run of a pink trim, normally white. Therefore, those who like to train with a little pop of color and you've been looking at starting BFR or it's time to update your BFR cuffs, get in quick as I only did a limited edition run of 50 units. From a podcast viewpoint, my goal is to improve the frequency of podcasts, although it's February, and I'm keen to get some more guests on as well. So if you are interested in hopping on the BFR Radio podcast, let me know. And this is the year for me to knuckle down and get my online BFR course up and running. There's been a pretty large demand for this course. Now that I've got the formalities out of the way, it's time to get in the podcast. I had an email recently from a customer who's been using BFR with different clients. And in particular, this one is around a 15-year-old male client of his, and he has Osteogenesis Imperfecta, commonly known as Brittle bone syndrome. To make things easier, I'm going to use the acronym OI from this point forward. I'll go through what OI is in a minute. However, for some more context, as the email inquiry went, he's not your typical presentation, 170 centimeters tall, but does have regular fractures. They've been working with him for over 12 months, and they're really strict on how they load him in the gym. They try to increase muscle mass and function with very gradual exposures to loading, and they're really keen to try BFR with him to see if he could tolerate it. And as their email went, they wanted to know if there is evidence on BFR and OI, thinking that it could potentially be great for him to use BFR to enable a better physiological stimulus without the added risk of loading him with weights. In short, there is no articles or research from what I can find on OI and BFR, but from a hypothetical mechanistic viewpoint and from other BFR training studies, especially in the topics of osteoporosis and bone reformation and formation, there could be some really great potential for him. To start with, a bit of background about what osteogenesis imperfecta is before I go through the hypothetical evidence for BFR. Now, here is my disclaimer. I'm by no means an expert in this area. So I've gone away, done my research for osteogenesis imperfecta, and hopefully I do this justice. Also, in this podcast, I'll mention a few mechanisms and markers. As always, I'll do my best to explain what they do. Don't worry about remembering the technical terms, but rather understand the themes. What is osteogenesis imperfecta? This is a rare genetic condition that affects the strength and structure of bones. People with OI have bones that break or fracture very easily, often from minimal trauma or in some cases without any clear cause. This fragility is due to a problem with collagen, which is a key protein that acts as the scaffolding or structural framework of bones. OI is primarily caused by mutations in the COL1A1 or COL1A2 genes, which are responsible for producing type 1 collagen. Type 1 collagen is a critical building block of bone tissue, giving bones their flexibility and strength. When these genes are mutated, collagen may be produced in insufficient amounts, leaving the bones under-supported. They could be structurally abnormal, meaning that the collagen framework is faulty and doesn't provide the necessary reinforcement for bone strength. Both of these issues make bones more fragile and prone to fractures. There's several types of OI, ranging from mild to severe. The first, type 1, mild OI, this is the most common and least severe form, where individuals may have normal or near normal height and experience fewer fractures. The second is type 3 and 4, which is moderate to severe OI, and these forms are associated with more frequent fractures, bone deformities, and reduced mobility. The third is type 2. This is the most severe form, often leading to life-threatening complications early in life. In addition to brittle bones, people with OI may experience other symptoms due to the widespread role of collagen in the body. It could be joint laxity or looseness. Collagen is also present in ligaments, so joints may be more flexible or prone to injury. Blue sclera. The whites of the eyes may appear bluish due to thinner connective tissue, allowing the underlying veins to show through. Hearing loss. Fragile bones in the ear can affect hearing over time. Dental issues. This is where teeth may be weaker, discolored, or prone to chipping because of abnormal dentin, which is a collagen-based layer in teeth. Because bones are more fragile, traditional high-impact or heavy resistance exercise may pose a pretty big risk of fractures for people with OI. While there are no direct studies on BFR use in OI, research has shown positive effects on bone markers in populations with low bone mass, such as those with osteoporosis. BFR training has been shown to significantly increase markers of bone formation, such as bone-specific alkaline phosphatase, or BALP, and procollagen type 1 N-terminal propeptide, or P1 and P, which are principal indicators of bone growth. Bone-specific alkaline phosphatase, or BALP, is an enzyme produced by bone-forming cells called osteoblasts. Think of BALP as a sign that the cells responsible for creating new bone tissue are active and working. And then there's procollagen type 1 N-terminal propeptide, a mouthful. Therefore, we'll call it P1 and P. This is a byproduct of collagen production. Collagen is the protein framework that gives bones their structure and strength. High levels of P1 and P in the blood means that collagen, and by extension of this, bone, is actively being reformed. To illustrate how BFR can help here, in a study of 18 healthy men, they walked for 15 minutes on a treadmill twice daily for 3 weeks and 6 days a week at a slow speed of 50 meters per minute. In comparison to the non-BFR control group, the addition of adding BFR cuffs to this walking protocol resulted in an 11% increase in BALB levels, along with an increase in lower body cross-sectional area and 1RM muscle strength. BFR training has been shown to improve bone resorption as well, which is the process by which old or damaged bone is broken down by specialized cells called osteoclasts. While this process is a normal part of bone remodeling, excessive bone resorption can lead to weaker bones and conditions like osteoporosis. One key marker of bone resorption is C-terminal telopeptide of type 1 collagen. Another mouthful, so we're going to call it CTX. Now, CTX is a small fragment of collagen. This is that protein framework of bone, released into the bloodstream when bone is broken down. Higher levels of CTX in the blood indicate that bone degradation is occurring more rapidly than bone formation. Studies have shown that BFR training can reduce CTX levels, suggesting a decrease in bone resorption. This means BFR may help shift the balance of bone remodeling towards more bone formation and less breakdown. To illustrate this, in a 12-week training study of osteoporotic women, they performed strength training under 4 different conditions. The first was a moderate high intensity using a load of 60 to 80% of 1RM. This is what we would normally associate weight training with, where they performed 3 sets of 10 reps. There was also a low intensity group using a load of 30% of 1RM. The third group was also another low intensity group using the same 30% of 1RM. However, they used the addition of BFR cuffs. And lastly, a control group. They didn't do anything. In both of the low intensity groups, they performed 3 sets of 20 reps for each exercise. The sessions consisted of double leg press, leg extension, dumbbell bicep curl, and tricep extension. A pretty straightforward session. Overall, the best intervention was the medium to high intensity session. However, the low load group with the addition of BFR did show a positive response. This BFR low intensity group showed a decrease in CTX values as well as an increase in P1NP. Remember again, this is the marker of bone formation. There was also an increase in the P1NP to CTX ratio, which was calculated as a ratio of bone remodeling by dividing the bone formation marker, P1NP, with the bone resorption marker, CTX. Training with BFR has also shown to improve bone mineral density. Some previous studies have shown that low-intensity BFR can lead to slight yet significant increases in bone mineral density, particularly in older adults or those with osteoporosis. Bone mineral density refers to the amount of minerals such as calcium and phosphorus present in a specific volume of bone. It is a key measurement of bone strength and overall health. Low bone mineral density indicates weakened bones that are more susceptible to fractures, which can lead to significant health complications, reduced mobility, and lower quality of life. Therefore, finding ways to improve bone mineral density is particularly important for individuals with conditions like OI, where bone fragility is already a concern. To illustrate how BFR can help here, in a 12-week training study of older women, this was a different study, they performed both leg curl and knee extension exercises 3 days a week. In the BFR low-intensity resistance group, which used a load of 20% of 1RM, they did 3 sets, where the first set was 25 reps, followed by 20 reps, and the third set was at 15 reps. They had a high-intensity resistance training group, where they performed our more typical or normal strength training type periodization at 70% of 1RM. They did 3 sets of 8 repetitions. And they also had another low-intensity resistance training group, but without the BFR, using 20% 1RM, 3 sets, first set 25, second set 20, and the third set 15 reps. Look at the results, performing low-intensity strength at 20% of 1RM with the addition of BFR cuffs significantly increased calcaneus bone mineral density compared to the low-intensity non-BFR group. The study also found that bone ALP levels, the marker of bone formation, significantly increased post-training in both the low-intensity BFR group and the high-intensity resistance training group, with a significant difference compared to the low-intensity non-BFR group. However, in this study, CTX levels, which remembering indicates the osteoclast activity, showed no significant changes across all groups before and after training. Another area we can look at too is collagen production and BFR training. In individuals with osteogenesis imperfecta, mutations in the COL1A1 and COL1A2 genes disrupt the production of type 1 collagen, that key structural protein that forms the foundation of bones and connective tissues. BFR training has been shown to increase the production of key growth factors that are important for collagen formation and bone remodeling. The first is insulin-like growth factor, or IGF-1, and this is a powerful signaling molecule that stimulates osteoblasts. This is that cell responsible for building new bone tissue. By activating osteoblasts, IGF-1 supports bone repair and regeneration. The next is through vascular endothelial growth factor, or VEGF. VEGF promotes the formation of new blood vessels, a process called angiogenesis, which improves blood flow and nutrient delivery to bones and tissues. This enhanced vascular network improves the delivery of oxygen and essential nutrients to bones, which is vital for maintaining bone health and repair. Furthermore, increase in VEGF directly stimulates the activity of osteoblasts. For individuals with OI where collagen production is compromised, stimulating these anabolic pathways through BFR training may help compensate for the impaired collagen synthesis. By enhancing the activity of osteoblasts and improving nutrient delivery via VEGF, BFR training could potentially strengthen bone tissue and promote repair. There are numerous studies highlighting how low-intensity BFR strength training at these low loads of 20 to 40% of 1RM can significantly increase these two markers, leading to this potential positive outcome. To quickly illustrate this and help draw similarities to the previous training studies, in one study, participants performed a single session of BFR single leg extensions at 20% of 1RM. They did 5 sets, where each set was reps performed to fatigue. VEGF was significantly elevated from their resting levels. And in the non-BFR group, they didn't show any increases in VEGF. This last point on VEGF and angiogenesis leads on to the next point, of which some studies suggest that individuals with osteogenesis imperfecta may have suboptimal vascular function, which means their blood vessels might not work as effectively as they should. This can lead to reduced delivery of oxygen and nutrients to tissues, potentially slowing down the repair of damaged bone and muscle. Since bone health depends on adequate blood flow to deliver nutrients and remove waste products, poor vascular function may further contribute to bone fragility in OI. Another potential mechanism linking BFR in this space is around hypoxia. In particular, BFR training creates a localized and temporary hypoxic environment, meaning that the working muscles receive less oxygen during exercise due to the cuff restriction. This oxygen deprivation stimulates the body to produce hypoxia-inducible factor 1 alpha. Again, for simplicity, HIF-1 alpha. This is a key regulator of the body's response to low oxygen levels. HIF-1 alpha triggers the production of vascular endothelial growth factor. That's VEGF. That's that molecule that promotes the growth of new blood vessels, angiogenesis, and enhances blood flow to affected areas. Looking at training studies, I'm hoping that you're starting to recognize some overlapping themes. I've already mentioned the increase in VEGF concentrations for a couple of studies. To further illustrate this, in another study, the participants performed double leg knee extensions twice a week for 8 weeks. A non-BFR and a low-load BFR group performed 3 to 4 sets of 15 reps at 20% of 1RM, whilst the high-load group performed 3 to 4 sets of 8 to 10 reps at that 80% of 1RM. HIF-1 alpha levels significantly increased in the low-load BFR group and exceeded those seen in the high-load and the low-load non-BFR groups. Furthermore, VEGF was increased in both low-load BFR and high-load groups. From a mechanistic pathway, hopefully this provides a potential for BFR in people with OI. Now, if you want to start BFR training, there's some guidelines when starting with BFR. And this was my recommendation to the original email inquiry. Potentially a little conservative, but yet something useful for anyone starting off with BFR, or more so with people in these special populations. If firstly we look at cuff pressure, in my opinion, you'd want to be using the lowest effective pressure. After calculating your training pressure, I would look to start at 20 mils of mercury less than what you calculated and spend at least 2 weeks increasing the pressure and total inflation time in one continuous bout. Initially, I would use an intermittent pressure protocol as well. So rather than inflating the cuff for 20 minutes in one bout, I would inflate for 1 to 2 sets, deflate the cuff, and build the number of sets that you stay inflated for over the period of time. Remember, 20 minutes total inflation in one bout for lower body and 15 minutes for the upper body. You can still perform more than 20 minutes of BFR in one session. You just need to deflate and reinflate. For the start of every session, I would also include a passive warm-up protocol to prepare the vasculature for the upcoming BFR. In this, you'd perform 4 sets of 40 seconds of inflation and 20 seconds of deflation of increasing pressure. The pressures are set against the calculated training pressure, where your first set would be minus 30, set 2 minus 20, set 3 minus 10, and set 4 would be at your calculated training pressure. Deflate and then reinflate for the start of your exercise set. If we look to sets and reps, in my opinion, I wouldn't use the 75 rep protocol. I would just use your normal sets and reps that you would prescribe, for example, 3x10 initially. Alternatively, first set, get the clients to do as many reps to the feeling of fullness in the muscle. They'll understand it when they're doing it. Either way, by the second set, especially if the cuff is kept inflated, they'll feel the effects of BFR. Some other monitoring feedback, which can be quite practical and important. The first is skin color. Your skin wants to be a dark reddish color when you're using BFR. If the skin is blue or purple, the cuff's a bit tight. The second concept is called capillary refill time. Now, the 2 areas we would check if you're doing upper body training, it is on your palm under your thumb, or if you're training your lower body, it's on your VMO. Here, you would press that area of the skin for a few seconds. Now, what you would notice is that as you push the skin, it would turn from that nice dark reddish color to a white. And then as you release it, it would return to that dark reddish color in about 3 to 4 seconds. If it takes 6 seconds or more, the cuff may be too tight. In other words, the blood can't get back through and refill the capillaries. Now, when we're looking at discomfort when you're using BFR, it's normal to have feelings of fatigue and sometimes that feeling of burning in the muscles. But any pain, usually greater than an RP of 8 out of 10, or numbness, stop your BFR, release the pressure. If you want to continue it for the rest of the session, check the position of the cuff, reinflate, and potentially just use a slightly lower pressure, 20 or 10 mils less band. Again, using skin color and capillary refill time. Now, if those two factors, and you're also having fatigue across all three sets, I think you're achieving the right kind of stimulus with the BFR. Then gradually increase the volume and intensity based on the tolerance, ensuring close monitoring of the client's response over the following 24 to 48 hours. Overall, I hope this opens your mind into potentially using BFR as a training tool that you may not have considered with this kind of population. And referring back to the client, the email that I received, he's actually tolerating his first few sessions of BFR really well. I am looking forward to hearing about his training journey. Pretty excited to see if BFR has been able to help in any kind of way. And that's all for this episode. If you have any questions related to this, you can get in touch with me through my website, which is thebfr.co, or through my socials at thebfr.co. You can also purchase your own BFR cuffs from our website. And lastly, before I go, a couple of favors from me to you. Firstly, if you know of someone who would benefit from this episode, please share it. And if you're enjoying their podcast, please give it a rating on iTunes. Thanks for listening, and remember to keep the pulse.